different classes of or different clusters of GDM. You have conventional GDM, which I am not going to go in detail of it. You have overt GDM, overt diabetes or overt diabetes in pregnancy, and that is what pre-gestational diabetes or diabetes in pregnancy DIP category of FIGO. eGDM has already been covered. Now we have mild GDM, which is called a gestational glucose intolerance. And what this is, when you give glucose and if your value is between 120 to 140, above 140 you call it as GDM. 120 to 140 because their cutoff is 120. Every day your pregnant woman is going to celebrate her pregnancy if you say she is negative, and you will cut off of 120 will further cross every day. So if you have 120 to 140, that's a warning sign to you, and you call it as GGI, gestational glucose intolerance. DIPSI has classified in 2006. And then we have papers with Canadian guidelines call it as if you have single test negative IGT of pregnancy. Canadian government, then Australia and New Zealand, they say call it as borderline GDM. Netherlands, they call it as mild GDM. So different classifications by different countries, different names. India, we call it as JGI. Earliest to call it as IABG. So we have a small data, early detection of mild GDM, its treatment can substantially reduce the fetal losses. So those women who has history of fetal losses, if you just isolate them from the total group of GGI, we have found around 209 women, 75% had positive family history, past history of abortion, 25% having single abortion, and 10% had multiple abortions, which has come down to 3.3% and hardly one IUD, and it was statistically significant just by a single diagnosis of blood glucose above 120, less than 140, and having BOH have been benefited. So mild GDM meta-analysis we have now, and I'll just go for the conclusion. The risk of severe adverse neonatal outcome, including small for gestational age and neonatal mortality, are not increased in mild GDM, but increased risk of most of the adverse maternal neonatal outcome were observed, and the risk have similar magnitude of for all mild GDM diagnostic classification versus the classical GDM. So mild GDM has to be respected now, and this is another data which was published in American Journal of Obstetric and Gynec. And this again says that if you have mild GDM, that also have the higher risk of having NI admissions and all. And the author has concluded that now fortunately we have some data and large scale multicentric trial, randomized treatment trial to provide an evidence that treatment of even mild GDM is important with simple dietary interventions. Sometimes insulin is necessary, and that can work for these patients. Now, are there any benefits of GDM in treating the lower level of hyperglycemia? Another Canadian study, they again says that the milder form of hyperglycemia has to be treated. And if you go through the CGM data in non-diabetic pregnant state, what is normal in non-diabetic pregnancy? 1 hour fasting never crosses 80, 1 hour never crosses 120, 2 hour never crosses 110, and 24 hours average is around 100. So if you have these figure in non-diabetic pregnancy, why should we go above this figure? If you go through the St. Vincent Declaration in 1985, what this says? It says we should try to achieve the glucose control of diabetic pregnancy to the non-diabetic pregnancy level, and these are those non-diabetic pregnancy level, and that's why possibly this 90 and 120 figures may need to brought down further in future. And I feel this has already been discussed about this new terminology, early gestational glucose intolerance, or EGGI. So it's another cluster which now Dr. Seshaya sir is working on, that you have metformin if given if you get someone of more than 110 blood glucose at 2 hours postprandial. I'm not going to go in detail of it because this was already covered. I'll have some small data from our group. This is about insulin in twin pregnancy. This is possibly one of the rarest data of this part of the country. And what we have seen, actually, one paper has come from type 1 diabetes from US, and that says insulin requiring in type 1 diabetic pregnancy, twin pregnancy, is almost double that of the singleton pregnancy. So we have a cohort of around 30-35 pregnancy. We also have cohort of around 8-10 pregnancies from Pune. So 2 centers have come out with the data, and Dr. Sanjay Gupta and Nagpur, and what we have seen, we had around 44 132 singleton pregnancy from the 800 records, and 44 twin pregnancies have been they're all GDM, And what we have, with 3:1 ratios, and what we have found that GDM women with twin or singleton gestation differed insignificantly in their treatment strategies and insulin doses. So that does not mean that if you have twin pregnancy, your insulin requirement will double. So insulin requirement need not be proportionate to the number of fetuses, and treatment should be planned to achieve the glycemic control similarly as that of the singleton pregnancy. There is another cohort which was got published last year in 2024, GDM neonatal and the maternal outcome in women treated with insulin versus diet therapy. And this cluster, you can understand that which kind of women will require diet therapy alone throughout the pregnancy, and which women is likely to require insulin along with medical nutrition therapy. Here are the highlights. Women receiving insulin had a has low risk of preterm, low birth weight and macrosomia. This is very important. That means if you treat them intensively through insulin therapy, if they are requiring it, you can certainly reduce the morbidity and mortality in these children. Neonatal hypoglycemia was more common in insulin treated group. That was expected because they were more severe hyperglycemia. 2 hour, this is important, 2 hour blood glucose values above 162.5 and fasting value more than 90 may require insulin therapy. This is at the time of diagnosis. Individual with the propensity score of more than 0.7 required higher insulin doses. So we have that data. I'll share with you what that propensity score is. There is another thing which is here, around 800 pregnancies. First trimester 13.5 have been diagnosed, second trimester 36.5%, and third trimester 50%. So it exactly matches with the global data as well as other Indian data you have, that almost 13-15% are being diagnosed in the early pregnancy. And then if you see which women is likely to require insulin, those who have elderly women, those who have bad obstetric history, positive family history and higher pre-pregnancy BMI, these are the women they might need insulin therapy versus the other women who require only diet therapy. Neonatal hypoglycemia is more common in insulin treated group, and PIH was also more common in insulin treated group. Macrosomia, this is neonatal hypoglycemia after the adjustment. Sir, I'll just take 1 minute more here. And this is risk of IUD was lower in the insulin treated group. Now we have initially in the full term doses of the insulin was calculated, and these two they have called it a love plot has been created just to match the population, and we have 4 cohorts of 4 different quarters, and what they have seen is first 3 quarters insulin requirements almost similar at the time of beginning as well as at the time of delivery, but the 4th quarter with higher risk factors of higher age, higher parity, BOH, family history and pre-pregnancy BMI, higher fasting, post-pregnant HbA1c required almost double the dose of insulin, 1.5 times double the dose of insulin. So if you have this, then these women may require higher dose of insulin. That has been shown. So this is about different cohort we can learn from the Indian population. National GDM Day is 10th March, which is the birthday of Professor Shia, and India is the only country in the world which we have National GDM Day. We should have awareness on these lines. We do this Prega talk now, the 3rd cycle has been started now in different, we have 22 languages in the Constitution of India, and we do this program. And yesterday we had Friday, and it was in Telugu, and earlier we had in Tamil as well as in other languages. So we have completed around 57 such programs. This is the Tamil one, we started the 3rd cycle, and Telugu we had yesterday. Focus on the fetus for the future is the mantra. There are some rewards and all which I am not going to tell much about, and with this I stop here. Thank you very much for patience.
Thank you, Dr. Sunil Gupta, for your elaborate talk on GDM clusters. Any question from the floor?
Bodharini, to your question. This is purely academic. That is adipocyte expandability in obese women, obese pregnancy without GDM versus obese with GDM. There is obese pregnancy with GDM. And what happens to fetal subcutaneous thickness? Obese versus, obese pregnancy without GDM and with GDM.
With GDM, even if the baby's weight is normal, you can see increased subcutaneous fat thickness. Weight of the baby may be normal. It may not be macrosomic at all, but still it will have more of subcutaneous tissue, and you should expect all the problems what I said in obese GDM in future.
This is regarding the metformin. On one side, like we mentioned, metformin is associated with obesity at the age of 7 and 9. And RSSDI is recommending not to use metformin, but use the only insulin. And, can you just clarify it, please?
There are some absolute contraindications for metformin. One should remember that. If you have placental insufficiency, missed abortions, oligohydramnias, polyhydramnias, you have any complication, PIH, in such patients, IUGR, then metformin is contraindicated in such patients. Rest of the patients, unless and it is contraindicated, those women who tolerate, we can give metformin. It has been now, if you go through the NICE guidelines, they have clearly said that we can continue metformin from the preconception till delivery after the MITI trial they have published recently. So on that basis, but Government of India guidelines are yet to be updated. We still say 20 weeks. DIPSI guidelines have last year changed from 20 to now it is 12. So 12 onwards we can give metformin to GDM, that's what we said. Again on the basis of that MITI trial.
And another endocrinologist from New Delhi, Dr. Saptaji Bhattacharya, he has followed the children who were on insulin as well as metformin up to 11 years. He has shown that both are equal. There's no difference between the two. And again he has shown that it can be used.
So
all the studies which we have mentioned, that MICTOFU, HAPO, everything is not India is not included in the studies. Okay, though it's a multi-centric, multinational studies with a large number of patients, that HAPO study. So India, China, they are not included. So our our genetic pattern is little different. So our people, they tolerate well metformin.
But most important message for all the clinicians, insulin remains the drug of choice because insulin doesn't cross the placenta. All oral drugs, they cross the placenta. So that has to be taken in consideration very strongly. Insulin remains the drug of choice.
thank you, sir.
And if you listen, what he has told us from PP 110 to 119. Up till that, this is useful. As sir said, beyond that it becomes GDM and they may progress to insulin requirement.
Thank you, sir, and thank you, ma'am, for your good talk on GDM. Now, since we are running short of time, we will close this session.